everyone. After much technical difficulties, me from Malaysia and Dr. Jeanette Chua from Malaysia are actually online. Okay, so today we'd like to chat more about what's going to happen in Milan. We want to talk, all of us place implants over here, but as periodontists, we would like to really emphasize something. We're not just talking about implants here. We want to talk about how we fine-tune the body in order to bring about success beyond the implant. We want to make it last as well. Let's start off with the next slide.
So as we all know, thank you, Marlene, as well. As we all know, that history of treated periodontal disease patients all have a higher risk of biologic complications. This, thanks to Lisa Hertz-Mayfield, 2009, alerted us and the whole community that dental implants in periodontal disease patients have an increased risk of complications. And of course, now, 20 years down the track, we know that treating periodontal disease prior to implant placements is mandatory. Nonetheless, we are still, as periodontists, Marlene and myself, every day when we see patients, we still struggle between how do we treatment plan and how do we ensure that we get the best value out of implants. We know that the risks and benefits of implants are there. Nonetheless, the last 20, 30 years, it has always been focused on implants being beneficial to be able to allow patients to restore their function, give you occlusive support, and it's a very fast treat. Nonetheless, over to you, Marlene. What are the risks?
Okay, I love implants, don't get me wrong, but we also see a lot of complications long term, right? So we've placed implants long enough to know that implants also can fail due to peri-implantitis. And some patients, after having implants put in, they feel that they lose proprioception. They don't feel eating as exciting, especially when it's a full arch. And also we need to add in the high cost of titanium, and that is translated to the patients. So what is the best treatment actually for our patients? Over to you, Jeanette.
So the questions to answer throughout our session, we would like to allude to the fact that how do we decide on implant therapy for stage 4 periodontitis patients and whether implants is absolutely the only solution or for everything else, every tooth that has periodontal disease. Then secondly, what leads our decision-making process, which we will share through our cases. And thirdly, other than SAC classification, which is how we risk manage and what ITI has built over the years to give us guidelines to ensure that we practice safely, what else more do we look at? So Marlene?
So let me share with you the story of one of my favorite patients. He did not start off this way. All right. So he's now one of my favorite people in the world. But when we first started out, we did not have a good relationship. He has been in and out of my office, but he came to look for me again. And I repeat again, because it feels like a push-pull on-off relationship. But he came to me in 2020. He told me that my teeth move in a day and my retainers are tight at night. And he says my gums keep bleeding. And he says, also, I know I grind my teeth. Okay, so let's see what's happening with this person. He says when he comes to me, we have a lot of issues over here. There's bone loss almost to the apex of 1-3, 2-3, 2-7, 3-7, and they're all super mobile. And 2-4 is a goner, right? It's a mobility of 3. It's depressible. There's really poor oral hygiene, really deep probing depths, and his gums are bleeding all over. I literally can't see my probe because I don't know what the probing depths are because it just like gushes blood. And he has multiple carious lesions, and there are a lot of abfaction cavities from heavy occlusion. Clearly, our diagnosis would be caries and abfaction cavities, but this patient also has stage 4 grade C periodontitis, and this is clearly associated with occlusal trauma because he knows he grinds and we see it all over the mouth as well. So when we run through the surgical SAC classification, you can see that it is super high. The surgical classification is really risky because let's say the 2-4 was eventually extracted. But when we look at just that site itself, it's going to be placed very close to the 3, assuming that we're going to keep the 3. So looking at this patient, it's not a very easy surgical case simply because of the pathology near the implant site, and his periodontal status is super unstable. Now, this is something interesting over here. What we noted in 2018, so he saw me in my previous practice and we knew that he had a vitamin D problem. His vitamin D was at a level of 5. Now, just to put things into context, a healthy range is actually 30 to 50 nanograms. So he fails. He doesn't fail. He fails by a very, very large margin. So that was the last time I saw him in 2018. I did not see him for a few years. So he shows up suddenly again in 2020 in my new office. Then he kind of disappears again and comes back again in February. So in February, he did another blood test, right? So he sends it to me because he knows I need a report done before I even touch our patients over here in Singapore. He needs fillings. He clearly needs periodontal treatment, which is scaling and root planing. His tooth 4 was extracted over the years. So from February to May, we execute these things. We also put him for night guards because he was grinding so hard. And we also indicated Botox injections to the masseters to lighten the load. Now, why do I send my patients for Botox? We actually, when there's stress, your masseters actually continue to clench and grind. So you put a lot of load on these teeth and it causes them to become even more mobile. So what I do to splint them, instead of using a wire, especially if it's a bad tooth, is that I use a Zendura. So a Zendura is like a Coke bottle. So it's stiff and hard and it wraps around the teeth. So it's like having a cast around your arm. So when you fracture your arm, you put something over. So I use a Zendura to basically immobilize his tooth. Okay, this is not his split, but just an example. And when you Botox them, it really lightens the load on their teeth. So again, our friend disappears before I could review him. So he had really active treatment between February to May, and then he disappears again. So I actually have no idea what happens to him. But then he comes back again and he shows up. Now in June 2022, after scaling and root planing and treatment, he suddenly shows up with perfect oral hygiene. So at this point, I'm not sure if I can trust him anymore. But what's really amazing is that his oral hygiene is excellent and all his teeth are firm. So don't forget that I haven't started on any periodontal regeneration yet. Gaps are still there. He's very little calculus, but there remains deep probing depths and bleeding and probing on these following teeth. Yeah, his canines, especially his molars, and in particular this anterior incisor. So this tooth has been lost quite some time ago. How did this condition improve? He was very faithful. He's been wearing his mouth guard faithfully. The Botox had already been done. His oral hygiene is immaculate and his vitamin D is now within range. Please note these points. But if you look at his CT scan, the conditions look dire actually. This is a CT scan where we sliced it at the midroot of the maxilla. And if you look at the 1-3, the bone loss is almost to the apex, but he's asymptomatic. There are no pulpal concerns. EPT is positive. 1-3 looks like this. 2-3 has lesion that's almost to the apex. And at 4-1, the bone loss has gone way past the apex, but these teeth are firm. And if you look at the other teeth, 1-6-4-6, all these are the teeth with deeper probing depths. 1-6-4-6, if you look at 2-6, it does not look great as well. This is the distal root. There's a lot of bone loss over there. And if you look at 3-7, does not look good. Bone loss all the way to the apex, almost to the apex, and also at 2-7. At 2-4, there's good horizontal bone width, but in order to get an implant over there, we're going to have to do an internal sinus lift. And don't forget, this is really close to the bone cavity next to 2-3, which makes it a very high-risk place to put an implant. So now we come to this question. Jeanette, you need to help me as well. All right, so we can discuss how we would rehabilitate this case. So I went back and forth many times, but our friend wants to keep his teeth. That is something that he would really like. All his teeth are firm. So they're good occlusal stops. It's not splayed out. The gaps between 2-3, this is not a single tooth gap. It's like 1.5 tooth gap. And then there's also a gap between 1-3 and 1-4. So what has happened is that these teeth have moved to a place of equilibrium. So the spacing is not quite right as well. 4-1, you saw that bone loss is already past the apex. 1-3 and 2-3 have really bad prognosis, and the molars have moderate to severe bone loss, but all the teeth are firm. So what the options do we have? We extract these teeth and then place the implants. So do an extraction for all the teeth with guarded prognosis. But our friend wants to keep his teeth. Do we regenerate the remaining teeth? Do we do orthodontic treatment because of all these gaps over here? But remember that when we do orthodontic treatment, his molars are actually not stable. So if we do embark on this orthodontic treatment, these molars are not going to be good anchors. So just a quick teaser. This is how we ended the
Milan.
case. Yeah, and I would say he's a really wonderful patient. We see him very regularly. But how did we get to this point? Jeanette, over to you while we discuss this case in Milan.
Yes. So I think one of the critical questions that I asked you when I first saw this case was, why did you do a blood test, and why you always do a blood test for a lot of your periodontal patients? And this is something that I hope we're going to discuss in Milan as well. Is that right?
Yes.
Good.
I do a blood test because the immune system is really, really so important for us as periodontists, but perhaps I'll share more in the lab.
Yes. Similarly, as what you were going through with periodontal disease patients, I think most of the time as periodontists, we're either called a villain or we're called a hero, especially when we practice implant dentistry. And like your case, we could have easily extracted a lot of teeth and replaced them with implants, or like you, we managed to keep the teeth and replaced it with, and replace the missing gap or the extracted really hopeless teeth with an implant. Thus, what is the line that we have to draw as periodontists is really quite hard. And I'm going to show you these two cases, but I'm only going to show you one case. We'll hope that this will explain as to why sometimes we do have to extract teeth and sometimes we don't have to extract teeth. So in the lens of any of us in the room now, some of us will have a bias lens, and we all have our biases because of how we are trained or what our background is. So in a case like this, where on the left side, the patient, where I was called a villain for actually restoring this case because it's almost a terminal dentition case, nonetheless, in a periodontal meeting, when I presented this case, I was literally called a villain. Why? Because there was, how could you have done that? Yes, Marlene. Because in the implant world, I'll be called a hero for saving the dentition when it's, and restoring it with implants because it's really a terminal case. But nonetheless, in the implant periodontal world, I was going, Dr. Jeanette, you are a periodontist. You should not be extracting all these teeth. So why? The teeth in questions were here on the lower jaw. We should have kept them. But how do we keep them? And what are the decision-making process that dictates whether we keep them or not is what I wanted to allude to. The case on the upper left doesn't look as badly affected as the top. Nonetheless, when we restored the upper jaw with implants on the upper jaw, I was called a hero for no good reason, just because I presented this case in an implant forum. So we do have to find out why and what are the tooth preservations to its limits, as do we really preserve every single tooth like in this situation. As you can see now in the photo from an x-ray is very deceiving. But in the photo, you can see that the bite is completely lost. This patient has lost function. And on the surgical classification at SAC, be it surgical or prosthodontic classification, the risk is extremely high due to the fact that even if periodontally, we do have supporting structure. Position-wise, we are not in a great position to be able to restore. Then, of course, we have to do digital planning nowadays, and how we deal with it to convince patient or to make proper decision making of what we want to do is through digital planning. And digital planning allows us nowadays to be able to facially generate and see the smile design. Secondly, map it back to the bone to look at the CBCT and look at where the bone structure is. Thirdly, look at the occlusion, look at the bite, and in relation, fourthly, to the existing tooth structure to really make a decision, should we or should we not keep the teeth? And thus, in the situation of the lower jaw, which I was alluded to, Dr. Jeanette, you should have kept the tooth. The reason why we really didn't keep the teeth was because we would have to not just do orthodontic movement of mesial-distal movement, but also to do intrusion. And that would have not been easy to do. And given that most of the molars are gone, a lot of teeth are missing, we went on to do a full arch treatment planning of upper and lower jaw. Nowadays, the fourth line or the fifth line that we're looking at is actually the airway as well. With the assessment of what we see now with digital planning, we can dictate and decide how we should wax up, where should we restore, what kind of prostheses we should have. Are we able to help the patients by readjusting and repositioning teeth in a better position? So why are we not looking at all about occlusion, dynamics of the muscular and structural issues, and all the bodily issues that Marlene has talked about as a whole for better health and better long-term success? And that's what we want to allude you to in order to get to this situation where we could actually restore upper and lower jaw with implants despite severe structural destruction. So all in all, our message is we believe in unified dentistry and wellness, and we wanted to talk about why we look at the patient as a whole. And we hope to see you in Milan. Over to you, Marlene. Maybe you can share how we met and how we've always been sisters. Yeah.
Oh, Jeanette, when I was studying, people used to say, "Oh, you should meet this person from Malaysia. She's exactly like you." And then I was so complimented when I met her in real life because Jeanette is my role model. So how we met was that we went for a toothbrushing. We
Oral
went,
B.
oh, we were the Oral-B KOLs and we met in Germany and we hit it off. And Jeanette has always mentored me. I look up to her so much. I feel so honored to share the stage with her in Milan and so grateful to be able to do this presentation with her as well. And today, what both of us stand for is that we're not just looking at one tooth or one implant or even the mouth. What we would like to present to everybody is that we need to look at the patient as a whole. And I think we come from different aspects and different perspectives just by our training. She looks at the airway, she looks at the occlusion. And for me, I really like to look at the body. I read blood tests as a hobby. So do come join us in Milan as we share our journey. And we would like to present treatment protocol that we wish a lot of periodontists and implantologists will adapt together with us. Over to you, Jeanette.
Thank you so much. I think that is the best summary of what we wanted to do in Milan. So we do hope to see you there in Milan and come join us. Yeah. Thank you. Bye.
Hi.